afternoon, good evening to all our global audience on behalf of YOSI, Young Ophthalmology Society of India, and WSPOS, the World Strabismus Pediatric Ophthalmology Society. I welcome you to this exciting session on ocular genetics. We have an esteemed panel today of experts who will guide us through evolving landscape of genetic counseling, testing and future directions in ophthalmology. There is a special interest of honoring going towards young ophthalmology, and we want all young ophthalmologists to be able to have this resource on their computers all over the globe. So it's my pleasure first to introduce my co-moderator and also a speaker today, Hannah Skanger. She's from the USA. She's a licensed and certified genetic counselor, supervisor of genetic counseling in the Division of Pediatric Ophthalmology, Strabismus, and Adult Mortality at UPMC Children's Hospital of Pittsburgh. She's part of the Department of Ophthalmology at the UPMC Vision Institute in Pittsburgh, Pennsylvania, and she specializes in genetic counseling for inherited ocular disorders and plays a key role in integrating genetics in ophthalmology. Over to you, Hannah, to introduce our speakers.
Yes, thank you, Aditya. It's my pleasure to share this with you. Welcome everyone to this Season 6 Webinar 4 for WSPOS and the Young Ophthalmology Society of India combined together to bring this to you. And I will share my screen so we can see our speaker panel today. So this webinar, it's In Our Genes from Code to Care. You've now met myself and my co-moderator, Aditya Sethi. Aditya, he is located in Gurgaon, India at the Arunodaya Eye Hospital. And this is our speaker panel for today. First, we have Deepika Parameshwarappa, and she is in the Narayanatralaya in Bengaluru in India. She is a consultant ophthalmologist in the vitreoretinal department, also has a specialty in inherited retinal diseases, ocular genetics, and electrophysiology. We also have Dr. Ken Nishal, located at UPMC Children's Hospital of Pittsburgh as Division Chief of Pediatric Ophthalmology. We also are going to be joined by Gaura Chetanavar. She is a pediatric ophthalmologist at the LV Prasad Institute in Hyderabad, India. For our discussants today, we also have some nice global representation for this webinar today, and ocular genetics and pediatric ophthalmologists from all over the world. So Aditya, would you like to introduce our discussants?
I would be honored. So our first panelist today is Dr. Divakant Mishra from India. He's a renowned ophthalmologist and expert in vitreoretina. He's also the president of a Young Ophthalmology Society of India and is actively involved in mentoring young ophthalmologists and is responsible for, to a large part of the current scenario of Yo movement in India. We also have the pleasure of having a key figure in pediatric ophthalmology, Dr. Eduardo Silva from Portugal. He's the director of pediatric ophthalmology department at Hospital Dona Estefania from São José in Lisbon, Portugal. He is highly regarded for his expertise in pediatric genetic eye diseases, particularly in congenital retinal disorders, gene therapy, and ocular imaging. We also have a well-known figure in the world of genetic ophthalmology with us, Dr. Elias. He's also with us today. He's the professor of ophthalmology at Case Western Reserve University and director of the Center of Genetic Eye Diseases at Cleveland Clinic. He also heads the division of pediatric ophthalmology and strabismus and serves as vice chair for education at Cole Eye Institute and Integrated Surgical Institute. His groundbreaking research in genetic eye diseases has shaped modern genetics, and I hear a new book in store for Sir to release very soon. We also have certainly, last but not certainly the least, Dr. Ramesh Kekania, sir. He's a leader in pediatric eye care and ocular genetics in India. He's a director of Child Sight Institute, CSI, and Center of Technology Innovation at LV Prasad Eye Institute, Hyderabad, Telangana, India. He specializes in pediatric cataract surgery, strabismus, genetic eye disorders, and has made numerous number of significant contributions to ocular genetics and pediatric ophthalmology in India.
Thank you. So certainly an exciting group that we have today. As the audience, when you're watching this, all the presentations and the discussion, we welcome your questions. Please type them into the YouTube comment section where they will be sent to us as moderators to make sure we get your questions answered today. And as part of your participation, there will be certificates. If you would like that, you can send an email to admin@wspos.org to obtain that. So we're ready to go with our first presentation. So Deepika, if you would please begin.
I'm just going to interrupt very briefly. Already we have listeners on the YouTube channel from Spain, India, UK, USA, Oman, Sweden, Chile, Canada, Bolivia, Kenya, Brazil, Argentina, and France. So a global audience already. Fabulous.
Truly, truly very global, and I hope this continues. And this will be all on YouTube for all of us to stream later as well. So don't worry if you're missing out. Our first speaker today is Dr. Deepika. She's a consultant ophthalmologist in the Narayan Valley, Bangalore, and she's going to talk about mastering genetic counseling in ophthalmology from genes to guidance. Over to you, Deepika.
All right. Thank you, Dr. Aditya. I hope my screen is visible and I'm audible. Thank you. Hello, everyone. At the outset, thank you, WSPOS and Team YOSI, for this opportunity to learn from all of you. Today, in my talk of From Genes to Guidance, I'll be taking you all through two inherited retinal disease cases, and we learn the finer aspects of genetic counseling through the case-based approach. And my first disclosure is that I'm not a certified genetic counselor, but I'm a clinician learning the crucial aspects of genetic counseling, because I believe that every clinician involved in the care of inherited eye diseases must understand these concepts and the implications of genetic counseling. So what happens in genetic counseling is it is a critical part of genetic evaluation. Through the pedigree evaluation, it provides us clue to pattern of inheritance and diagnosis sometimes. It also identifies at-risk family members. It provides insights on ethnic similarities, consanguinity, and constricted gene pool. And the most important point, which every patient goes through in an IRD or any ocular genetic condition, is that psychosocial aspect of whether it is guilt, anxiousness, social stigma. So genetic counseling takes care of that. So it involves both psychosocial as well as some kind of reproductive options for patients and family members affected with these diseases. By all these evaluation, it guides in choosing the type of genetic testing to be performed. So these all things happen in the pre-test part, and once the test has come back, which we call it as post-test counseling, all the information which is got from here will be put together with patient phenotype, and the discussion from there will be the unique point to conclude a case or to go ahead further. So I begin with my first case is a 3-year-old girl with history of nystagmus and light sensitivity, first noticed at around 6 months of age. The child also had tendency to keep the eyes closed for room light and sunlight. The child was more comfortable in dim light or during evening. It also kept the objects very closely while looking at them. The vision was 6/60 with a high hyperopic refraction. This is a fundus picture, the color optos picture. Apart from these reflexes in the left eye, which are more prominent, and some pigmentary abnormalities, we don't see anything remarkable in this. Well, the autofluorescence showed us more, where in both eyes, the fundus autofluorescence, we can see that at the fovea, there is increased signal. We call it a central foveal hyper autofluorescence. And in the OCT, it was difficult to capture because of the nystagmus, also the young age, but we really got some good scan by this 3-year-old child through HRA spectralis. What we can see here is the inner retinal layers are good. The outer retinal layers are pretty well in arrangement. The ellipsoid zone, which, if we look very carefully, it is slightly less prominent, though we cannot say that it is a complete loss or something. Further, the child attended genetic counseling, detailed pedigree. And by pedigree, as we can see here, there was history of consanguinity in parents. There was a younger male sibling who was affected with exactly the similar history. The vision of the younger sibling over here is 24/70, and again hyperopic refraction. The fundus was unremarkable because of the age 2-year-old. We could not take much imaging. Here, how did the genetic part, the counseling, pedigree, and detailed history helped us? It is sort of giving us a clue to the pattern of inheritance, which could be autosomal recessive over here. It provided us that there is history of consanguinity and two of the kids being affected. It helped in decision making for who will be the first going for genetic testing and what test will be chosen, which I'll be covering in this slide. So summary so far with these kids, two siblings with early onset nystagmus, photophobia, high hyperopia, fundus unremarkable clinically. But if we put the symptoms together and also the fundus autofluorescence, it indicates towards a severe cone dysfunction phenotype in the young kids. And so elder sibling with all the strong history, and also we have strong imaging findings in this. So we will always choose the test for the proband or for a patient for whom we have a strong phenotypic evidence. So here the elder sibling with strong phenotypic evidence of severe cone dysfunction was advised for genetic testing. And once the test was back, we did a clinical exome sequencing for the 3-year-old child. We found likely pathogenic homozygous missense variant in exon 8 of the CNGA3 gene, which is known to cause achromatopsia in autosomal recessive inheritance. So put together both the phenotype and the genotype, they're very well correlated in this case. And this is a good example for how, if we do a stepwise approach from a detailed history, pedigree, pre-test counseling, imaging, and post that genetic counseling, so we get a good information and good correlation with respect to how the child presented and how we can handle the diagnosis. So now for the plan, which is kind of post-test counseling in coordination with both the genetic counselor and the clinician. So now we have a lot of knowledge and information to share with the patient because we have a confirmatory diagnosis. So we can explain that the prognostication specific to CNGA3 achromatopsia, which is considered mostly stationary, though there is debate that some of the achromatopsia can progress slowly. For us to decide on this child who is very young, that is 3 year, I think it should be just only reassurance in terms of like it is mostly stationary and your nystagmus can become better over time, and we will see how the vision improves over time, because they are known to have some visual impairment because of the natural visual maturation of the kid. And we can also provide knowledge and education on the CNGA3 related latest research, because for achromatopsia, approximately, I think around 5 gene therapy trials are ongoing, with some of them with good results. The next will be to address the point of guilt or emotional burden of parents with respect to the consanguinity, because they might be thinking that their consanguinity and being a carrier for one copy of each defective CNGA3 gene and passed on to not just the one kid, and two of the kids are affected. So the next step to dig more further into the genetics will be parental validation, targeted testing for affected younger sibling, because the phenotype is strongly as similar to the uh, elder one, that is the 3-year-old. So we can directly go for a targeted testing, carrier testing for the unaffected elder sibling. Regular follow-ups are required with the hyperopic glasses, visual assessment, the filters for achromatopsia. Of course, those are the mainstay, because they do very well, these filters for achromatopsia, and we should definitely do ERG in follow-up visit. So this is in summary of my case 1. I'll move to case 2, which is actually not a pediatric case, but we do encounter these kind of situation in the pediatric IRDs as well. So that's why I've chosen this case. This is a 57-year-old male who had history of nyctalopia, peripheral vision problems, first noted at around 30 years of his age, eventually central vision concerns as well. Vision was very low when he presented to us, that is counting finger 1 meter. He was also diabetic and hypertensive for the past 10 years. This is how the fundus looked. We can see that there is attenuated vasculature, chorioretinal atrophy, and pigment spicules. The autofluorescence was more evident of the changes which is happening in the photoreceptor and retinal pigment epithelium health, where we can see macular hyperautofluorescence and surrounding hypoautofluorescent patches correlating to the atrophy. OCT, as expected, showed a severe outer retinal loss and tapering of the outer retinal layers starting from even outer plexiform, outer nuclear, and involvement of the RPE as well. So this patient underwent pre-test genetic counseling with the detailed pedigree charting. So what we can see here is very interesting and also intriguing. This is our proband, 57-year-old male, who is consanguineously married, who also has a younger female sibling, who is again affected with RP. And on the other side of the family, that is from the maternal side, we do see consanguinity in grandparents. There are two uncles who are affected with RP, and then a distant cousin, male cousin, who is also affected with RP. One interesting point to note over here, which I'll be covering in the next slides also, the daughter of proband is again consanguineously married, and they are yet to have their children. So this is a complex pedigree with multiple members affected and consanguinity at multiple generations. So we had a phenotypic examination for the younger sibling and also one of the distant cousin, which I'll briefly show now. This is proband's younger sister, 55-year-old female, vision of 624, classical retinitis pigmentosa phenotype. The autofluorescence showed us hyperautofluorescent ring, which we actually did not see in the brother. This also showed some hypoautofluorescent patches with some normal autofluorescence in between. Again, interesting to say, we did not see so much of chorioretinal atrophy, which we saw in the brother. This slightly different, though the age difference is 2 years only. And the symptoms onset for the younger sister as well as the distant cousin was around 28 to 30 years as per history. OCT, there was parafoveal tapering, but some amount of ellipsoid zone at the subfoveal region was preserved. This is a distant cousin who is younger again, 46-year-old male. His central vision is absolutely good, 6/6 and N6. Fundus shows retinitis pigmentosa phenotype, and his phenotype is similar to what we saw in the previous one, that is proband's younger sister. Hyperautofluorescent ring, and in the OCT, there is a good subfoveal preservation of all the outer retinal layers. So with this background, if you put all these together, so the proband 57-year-old has a phenotype like this with chorioretinal atrophic patches and central macular hyperautofluorescence. On the other hand, this proband sister, who is just 2 years younger to the proband, and proband's cousin have a similar looking phenotype. So the summary, proband definitely has a severe RP phenotype. He's also older when compared to the other ones, but he strikingly, it looks different in autofluorescence. That's what I meant. Now we don't know whether we are dealing with a monogenic IRD or there is one or more than genes which could be causing this phenotype. And proband's daughter, who is consanguineously married, is also planning family. So with this background, for the proband, we initiated the exome sequencing. Proband's daughter and son-in-law, who were in actually care with the clinical genetics and obstetrician medical genetics part, so they advised whole exome couple carrier screening for the proband's daughter and son-in-law. Let us see how the results are. For the proband's exome sequencing, what we got was likely pathogenic homozygous nonsense variant in the EYS gene, which is known to cause autosomal recessive retinitis pigmentosa. The second finding was likely pathogenic heterozygous splice site variant in IFT43 gene, which is also known to cause autosomal recessive RP. What we saw in the couples, that is proband's daughter and proband's son-in-law, was both of them were heterozygous, that is carriers for EYS, the defective copy. Additionally, they were also heterozygous for this nonsense variant in INPP5E gene, which is known to cause autosomal recessive Joubert syndrome. Couple karyotype was normal. So for the plan, so then when they came for the post-test counseling, prognostication, here of course proband already has a severe phenotype. Rehabilitation and mobility training is the key for here. Testing for younger sister who is affected, distant cousin. their children, and also important is children born to the consanguineous parents, because we saw some of the families where there was consanguineous marriage, but children so far are not examined, or we don't know whether they're going to manifest with symptoms or not, because all three who we examined had a later onset RP phenotype. Our daughter is having ongoing evaluation with the clinical genetics, and they're going through the process of IVF. So here in this case, how did the detailed history, genetic evaluation, examining family members, genetic counseling, pre and post test helped us is, it helped us in the first 3 points, like the previous case, that is pattern of inheritance, the constricted pool, ethnic similarities, helped in decision making for at least the proband and the daughter. It also gave us information on choosing the at-risk family members. Slightly, it raised the possibility of additional genotype or modifiers on some different phenotypic presentation, though everyone presented with the same age of onset. So this is, I will end over here. I'd be very grateful if I could get some thoughts from the panels. Does the proband has only EYS related autosomal recessive RP or something in addition? And what type of testing should we choose for younger sister and distant cousin? Because I'm not sure whether targeted testing is the go here, like the first scenario, or should we check a broader exome sequencing? Any suggestions on proband's daughter and husband's family planning? That's it from my side. Thank you, everyone. Thank you for the opportunity. Over to you, Dr. Aditya.
Thank you, Dr. Deepika, for that very insightful presentation. You made genetic counseling seem very easy. So before we go to the panel for a comment regarding your presentation, I would like to ask you something, which just rolling a little bit back. What do you think, in your experience, are the biggest challenges ophthalmologists face integrating genetic counseling into routine practice? Maybe we can have a few points only, because I'm sure you will address a lot of these points later in this webinar. And one of them, of course, I'll partly answer your question, is about how genetic counseling actually requires a lot of training, the right people and the right approach to do it, and that itself requires somebody who's trained in that. So that itself can be a drawback. But yeah, over to you.
Thank you for the question, Dr. Aditya. Yes, definitely the first and foremost important aspect is the training. And along with the training, we need people who are certified to take care of these patients, whether it is any pediatric ocular genetic condition or an inherited retinal diseases. We need specialists for that. So with respect to clinician perspective, we definitely need clinicians who are trained in these aspects, or who have a keen interest to learn about this. So that will be first one. The second one, genetic counseling. I would say a good genetic counselor is a great gift to clinician, because at least in our scenario, I'm sure you would agree, and others in our setting would agree, it is very difficult for us to give that time which requires for genetic counseling, because minimum it requires 45 minutes. So we need people or whom we can train in some certain aspects of genetic counseling, whether it with respect to just drawing a pedigree and taking the history and guiding them towards the genetic testing. We need a specific people for that. So that is the second one. The third one in genetic approach is definitely the affordability for the genetic testing in India, because we all know that right now our patients are spending their own money from their pocket for genetic testing, which is not the case in few of the countries. I think that should be our next goal. And also patients' knowledge on understanding these concepts of a genetic disease, and how they take up the diagnosis, prognosis, and their future planning with respect to whether it's kids' career or the understanding of the parents. I think the patient's knowledge and education also makes a huge difference in managing these cases. Thank you.
Yep. And Dr. Deepika, I would agree with a lot of the points you made, especially about how complex it is. And I really view the role of the genetic counselor and the ophthalmologist in our subspecialty as really partners in care. Because the ophthalmologist obviously can do all the things that us as trained genetic counselors are unable to. And then we bring that skill set to complement what you're doing with the clinical phenotyping and thinking about prognosis and all the management aspects. So I think the complexities of what we each do together is really what brings out the specialty of ocular genetics. You did mention in your presentation exome sequencing as your approach to genetic testing. And so we do have a question from the audience that I would like to pose to some of our panelists. Aside from the indication for exome for your retinal diseases, the audience is asking, you often come up with findings completely unrelated to the reason for testing. And they wanted to know, is it worth even looking at those incidental findings? Dr. Silva, could you address that question?
Good afternoon, good morning, good evening, everyone. Thank you very much for the question. I would like to add something to what Deepika just said, which are the legal issues, because I think that people should be aware that in every country there are legal limits towards what you're allowed to do and not allowed to do. In the family that you first presented with achromatopsia, there's an apparent healthy sibling. And in my country, in Portugal, the only people that are allowed to ask for genetic testing are certified geneticists. So no one else for healthy individuals can do that. That's point number one. Number two is that the first, obviously that first family is relatively straightforward. So the approach could be either exome or simply a panel that is directed, because the phenotype is so specific and so highly suggestive of achromatopsia to start with, that probably that could be the option, and you can save a few euros or whatever your currency is when testing that. With regards to the incidental findings that you have, you really have to put that into perspective. And again, I think that the geneticist should be called into place, because if you're not an expert in, let's say, oncology or any other subspecialty, and you find a BRCA1 or BRCA2 variant, pathogenic variant, then that is something that the ophthalmologist should not be the one to address. But the multidisciplinary approach should be key here.
Thank you. Excellent point. And we, in the interest of time, we certainly will have some more discussion later, but you brought up some interesting points that our audience are also asking about is, what about asymptomatic siblings? So in that first pedigree, we have the 6-year-old, we would have expected clinical features of achromatopsia. So, we're thinking about that. For me, that's uncovering a carrier status. That brings in all sorts of legal and consent issues when we think about what it means for somebody young versus old, when they're thinking about the family planning situation, whatever the consent age and assent age is in each of our respective nations. So certainly things that we're thinking about, but we would like to make sure we have time for all of our presentations and discussions. So next we'd like to switch to Dr. Gora to present about the DNA dilemma, what genetic tests to order, how they're interpreted, and when to order, which I think will go really nicely with the presentation and the questions we're already seeing here today.
I'm just going to interrupt again. So we've got Poland, Italy, Serbia, Qatar, Kurdistan, Philippines, Portugal, Nigeria, South Africa, Denmark, Germany, Ireland, and Scotland. So thanks, everyone.
Hannah, I also would like to interrupt.
Yeah.
Just one quick comment about the first case that was presented. In view of the great disparity in the availability and the cost of genetic testing around the world, one prudent way of doing things is that if you know clinically what the diagnosis is, I mean, this patient clearly has achromatopsia, and you have access to an ERG to document it, I would say it would be very reasonable not to get genetic testing, because immediately there's no actionable thing that relates to the specific identification of the gene. I know this goes against precision medicine, which is what we would like to practice, but at the same time, in view of everything else that we talked about, especially if the diagnosis is very clear, and you mentioned that, I think that would be a very reasonable approach. The second family that was presented is much more complicated, a multitude of possible genes, reproductive counseling, etc., etc. So there, I would say it's absolutely necessary if we want to give the best possible care to get the testing.
Yes, always coming back to that clinical diagnosis, because we know not everywhere can access genetic testing, or even comprehensive enough just for the genes for achromatopsia may not even be possible. So certainly important to always come back to that clinical diagnosis. Thank you, Dr. Trabulsi.
Hello, everyone. Are my slides visible and I'm audible? Hello, everyone. So I think Deepika put up a very good platform for me to present on the genetic testing of when, what, and how. So let's quickly dive into it. And when a genetic testing is ordered is when you have a strong phenotype, when your clinical suspicion is very strong, when there is a family history, and when the diagnosis is uncertain with the available diagnostic methodology of the acquired causes, and you want to explore a different other treatment options. So what are the different types of genetic testing that are available? We starts from targeted single gene testing to single gene, a gene panel, a exome sequencing, a whole mitome sequencing, which includes the mitochondrial genes and also the nuclear genes that affect the mitochondria, the whole genome sequencing, and sometimes there could be chromosomal structural changes that could also be present. And in that case, you would order a karyotype. And also to identify if there are any copy number variations, you would order a chromosomal microarray. The newer tests that are available are the gene expression studies, the epigenomics, and the proteomics. So let's understand few of these tests through a case series. So let's understand a 16-year-old female who presented to us with central blurring of vision in both eyes for the past 6 months. Her visual acuity in both eyes was 20/60. She had no nyctalopia, no photophobia, and her ERG was normal. The only significant history was the second-degree parental consanguinity. This is her clinical pictures, and you can see the disc is healthy. The blood vessels are absolutely normal. The central macular atrophy, and there are hyperautofluorescent flecks in the posterior pole extending nasal to the disc, but the significant pattern is the peripapillary sparing of these flecks. And there's a vermilion fundus, that is, you're not able to see the choroidal details through this fundus. So when you look at this clinical picture, it's so very typical of ABCA4 associated macular dystrophy. In such a case, you can just order a single gene testing. And for this test patient, we ordered a single gene for ABCA4, which identified 2 variants. Let's dive into the case 2, who also presented with central blurring of vision of a 16-year-old boy, whose visual acuity was 20/80. Clinical features were similar to what was seen previously with the macular dystrophy, but there were no flecks that were seen. The OCT showed that there was parafoveal thinning of the ellipsoid zone and the photoreceptor layer. So this was suspected to have a macular dystrophy, as ERG was normal. Here, since we did not have a typical feature of any pointing towards a specific gene, there could be 2 options here: either get a panel testing for macular dystrophy, but at India currently, as we do not have the panel testing, we ordered the whole exome sequencing, and this patient was found to have a nonsense homozygous pathogenic variant in SAMD7 gene, which causes macular dystrophy. Let's see a case 3 of a 3-year-old girl who presented with megalocornea and central corneal haze of grade 2. Her intraocular pressures were high, and she also had myopia of -10 diopter spheres in both eyes. On further clinical examination, we found that she also had a blue sclera. The clinical suspicion was primary congenital glaucoma. She had no other systemic features and no parental consanguinity. Here, because of the non-availability of the other testing methodology, we ordered the whole exome sequencing. And this is her genetic result, where you can see a heterozygous missense variant in the TEC gene and a nonsense variant, a homozygous variant in the PRDM5 gene. So the point of presenting this case is the TEC gene explains the glaucoma, and the PRDM5, which is associated with the brittle cornea syndrome, explains the blue sclera and myopia. So this case highlights that the 2 different conditions can simultaneously be present in a single patient, and we should always keep this in mind. So this is the most common scenario that we see over in the clinic of ectopia lentis with marphonoid habitus with a positive wrist and the thumb sign, and dilated aortic root on the 2D echocardiogram with the normal homocysteine levels. So why am I presenting this case? It's such a common case is to highlight that a single gene can be expressing in the multiple systems. So whenever there is a multiple system disorder, if a single gene can explain most of the clinical features, you can go ahead with just a single gene testing, or if not available, you can go ahead with a whole exome sequencing. So as suspected, this patient had a Marfan syndrome with a missense variant in the fibrillin 1 gene. Likewise, this was another patient with multisystem disorders, but with an ocular cutaneous albinism. She also had a significant history of congenital heart disease and developmental delay. How often do we see ocular cutaneous albinism associated with congenital heart disease and developmental delay? Not very often. So we dug into the literature and did not come across any single gene that could explain all the clinical features of this patient. So we were suspecting where multiple genes were involved in this patient. So when you have a multisystem disorder which is not explained by a single gene, always suspect that could be multiple genes that could be affected. In that case, you can order a chromosomal microarray. So the chromosomal microarray for this patient showed a homozygous deletion in chromosome 11. And these are the coordinates of the deletion that was reported for this patient. On further analysis of the chromosomal microarray results, we found that this homozygous deletion in chromosome 11 contains 3 genes, that is GRM5, NOX4, and TYR gene. The GRM5 gene explains the intellectual disability and developmental delay for this patient, and the NOX4 gene is associated with cell migration disorders, which explains the congenital heart disease in the patient, and the TYR gene explains the ocular cutaneous albinism. So the last 2 cases highlight that if there is a multi-system disorder, if a single gene can explain the multiple system involvement, go ahead for a single gene testing or a whole exome sequencing based on the availability of the testing methodology. But if you're suspecting there could be multiple genes that could be affected in a patient, you can always get a chromosomal microarray. So that is how you can choose a different testing methodology for your patients based on the clinical phenotype. Now let's quickly look into how a typical genetic report looks like. So this is how a typical report looks. So the first column is usually the gene that is affected with a transcript that has been used to analyze the genetic variant for this patient. The second column is the DNA change and the corresponding protein change. The third column is usually the zygosity, whether it is in heterozygous or in the homozygous state. The next important column would be the condition associated with this gene and the inheritance pattern, either if it is autosomal dominant, autosomal recessive, or X-linked. The last column is the most important column for any gene variant that is reported is the variant classification. Let us understand each of these with a few case examples. So what are the types of gene changes that are present in any person? So a gene change that does not cause a disease is called as a polymorphism, and that is responsible for the diversity and sometimes even adaptation to survive better. Any change in DNA that causes a disease was earlier called as mutation, but we no longer use the term mutation. We use the term pathogenic variant, and this pathogenic variant can be present either at a somatic or a germline level. And what are the types of genetic changes that you would be expecting? So if you're it could be at a level of a chromosome, where it could be a structural abnormality such as inversion, translocation, or could be a copy number variation such as duplications and deletions. At a DNA level, you can have a single nucleotide changes, could be a substitution such as a missense or a nonsense change, or a frame shift change, and a deletion and an insertion or a splice altering change. Let's jump on to the zygosity. As you can see over here, if the same variant is present on the 2 opposite copies of the gene, we call it as a homozygosity. And if a variant is present only on the 1 copy of the gene, we call it as a heterozygous state. If there are 2 different variants but are present on the opposite copies of the gene, it's called as a compound heterozygous state. So for an autosomal dominant inheritance to present, heterozygous state is enough. But while for autosomal recessive inheritance pattern to express the disease, it should be either in the homozygous or in the compound heterozygous state. Let's understand with few case examples over here. So these are two unrelated patients who presented with primary congenital glaucoma. In the case one, as you can see, there is a missense change in the CYP1B1 variant in a homozygous state, which is pathogenic. So this explains that the patient is having the primary congenital glaucoma. While the case 2, there are two different variants, two missense variants in the CYP1B1 gene in a heterozygous state where both are pathogenic. So for us to understand if this gene is the causative gene for primary congenital glaucoma in this patient, we need the parental segregation to understand the phase of these two variants.
Dr. Gora, for time, can we just quickly wrap up the presentation?
Yes, I just have 2 minutes. So what are the possibilities of these two variants being in the trans configuration? So the first configuration where the two variants are inherited from the mother. In the second scenario would be the two variants inherited from the father. But these two possibilities do not explain the autosomal recessive inheritance. It's only in the trans configuration when these two variants are present on the opposite copies that explain the autosomal recessive inheritance. Last but not the least is the variant classification, where it ranges from benign to likely benign to uncertain significance to likely pathogenic and pathogenic. And this is all based on the different levels of evidence that are present for the variant classification. I would like to remind everyone that it is a dynamic classification, that is, what is VUS today can be downgraded to likely benign later or could be upgraded to a likely pathogenic based on the evidence that could be available at that point of time. The most common scenario that we see is the negative results, because sometimes we have the strong phenotype, but the result comes negative. There are various reasons that could be a possibility. One would be the wrong diagnosis, wrong testing, sometimes inadequate sample, or the wrong gene that has been testing, or sometimes the gene is not discovered yet. Or there could be deep intronic or a promoter region chain, and sometimes the epigenetics also play a role. So we looked into the strong clinical and suspicion, and the family history points towards the genetic testing. The type of genetic testing depends upon the phenotype and multiple system involvement, and points towards either you can get a single gene testing or a chromosomal microarray. Interpreting genetic results with the different levels of evidence is a key role, and always look at negative results with a pinch of salt. Thank you, everyone.
Thank you, Dr. Gora. I think that was a very wholesome presentation. I think you covered almost everything on a very important topic about what tests to order and what sort of approach you should have. Not only is it important, it's also very important to be cost effective, especially in developing countries. I would like to ask Dr. Ramesh if his view on what sort of outline does he have or approach he has when ordering DNA testing. Because we know there are often limitations, like we don't have a lot of panels already in place. So what is his approach, Dr. Ramesh?
Yeah, thanks, Aditya, for that question. See, when you order, obviously you'll have to do all the things what is required, because in genetics, anytime the phenotype is the king, because that's where you need to. Once you make that, the next thing is we have to look into, because there are audience from different parts of the world here, right? It depends upon what is available, what is the condition of the patient. Depending upon that, we can really advise. For example, if somebody comes with the typical Marfan syndrome features, if the patients cannot afford any kind of testing or something, doing a very, very deep phenotype with getting an echocardiography can be sight-saving as well as life-saving for that particular patient. But if somebody has everything, but I'll get, thinking that it's homocysteine and things like that, and then obviously I will do that, because genetic testing and the counseling is a spectrum. I think Deepika showed a very nice slide on the initial part. How much you can go, it depends upon your patient setup and also their socio-economic and cultural situation. Depending upon that, we can do it. That's why the pre-test counseling is very, very important. All of this needs to be understood. And then I think Gaura has already shown in different scenarios what can be done. But my only point is, Ilyas also said about it, In some of the situations, even if you don't do, it's okay. As long as being a clinician, if you pick up those phenotyping features, which are very typical, is important. Thank you.
Dr. Elias, just one quick comment from you as far as the global scenario is concerned. How do we handle these? A lot of times we get this inconclusive or negative genetic test result. As a clinician, it may be something, and then you get this inconclusive result. What sort of approach do you teach your students then? What should they do next?
Is the question for me?
Yeah.
Aditya?
For
Okay.
you, sir.
So we do get quite a few negative results in patients with retinal dystrophies across the board. It's about 30% or so of cases, and sometimes it's you made the wrong diagnosis, that it's not a retinal dystrophy, that it's a post-inflammatory disorder or a cancer-associated retinopathy or an immune retinopathy or a vitamin A deficiency. You know, there are some parts of the world where that would be really an important cause. As Ramesh mentioned, you have to fall back on your clinical pictures and see what you say. The other thing that is quite common is a misinterpretation or a misreading of the report. The reports may come and read negative because whatever variants they found, they couldn't classify them or link them to the clinical disease. Or they may say likely pathogenic or variant of uncertain significance, and then the overall interpretation is that it's a negative result. But if you take that variant of uncertain significance and you add it to a definitely positive clinical diagnosis, then that variant of uncertain significance for the lab is very significant for you as a clinician, and then you might accept it as the cause of the disease in your patient and take it as such. So consider the wrong clinical diagnosis, rethink, start from scratch, rethink the case as you do, think about alternative diagnosis, and read that report very carefully, or better, have a geneticist or a genetic counselor interpret it for you in view of the clinical picture of your patient.
Thank you for reiterating the team approach. In view of time, I'm going to go to our next speaker, who's none other than my co-moderator, Dr. Hannah. She's a licensed certified genetic counselor from UPMC, USA, and she's going to talk and present on decoding the mystery phenotype-genotype correlations in pediatric and adult patients. Over to you, Dr. Hannah.
I'm going to interrupt again. This is very interesting. We've got Tanzania, Namibia, Zimbabwe, and we have one listener who's on a plane flying from the UK to Greece. So we're in airspace as well.
We've entered all zones of the atmosphere. And I know we're getting a lot of questions. In case we don't answer your question, we'll send you an email with an answer from all our expert panels here. So don't worry.
Thank you. Thank you for the invitation. So today I'll be discussing phenotype-genotype correlations. We've already had a lot of discussion on that today, and through two cases, hopefully showing you again why that's so important. So remembering about the difference of phenotype versus genotype, right? Our phenotype is what we're observing in the clinic, all the tools that we have in ophthalmology to do that, and keeping in mind that it's also the result of genes, but environment. We do have some critical ones in ophthalmology, like the lifestyle modifications we think about when people are diagnosed with LHON, like excessive alcohol intake, smoking exposures, things that stress the mitochondria that can exacerbate a phenotype. And that's versus genotype, right? The genetic makeup. And these genotypes can be very discrete, like we've talked about already, individual mutations or pathogenic variants across genes, or very broad if we're thinking about multiple diagnoses and interactions across our genes and proteins. And people usually think of these as verses, but I like to think about them as the two together. That's what we do in ocular genetics. We take, what are we seeing in the phenotype? What does it look like in the genotype? And going back and forth between the two, because it's constantly evolving. This is a little bit of an older schematic, but I really like it. It's from a pharmacogenetics perspective, but thinking about how complex this is more than just what are we observing and more than what did that report say. This really comes down to everything that we're expanding into proteomics, into epigenetics, expression, how it's influenced with something like medications or anything like that, as this slide shows. So this is more than just these two terms. It is definitely quite complex. But in ophthalmology, we have the tools, and this is what I really enjoy about our subspecialty, is we have lots of different elements to deeply phenotype the patient the best as possible. Even in the absence of doing a genetic test, we can still get to very important clinical diagnoses that can guide care, that can guide counseling even without a genetic test result, and management, as we saw in some of the cases already presented today. So as we use these tools, we can get to answers and hopefully, if we're able to, get the genetic testing done as well. So I'd like to give you two illustrative cases of this, and thinking about across the whole lifespan. We're thinking even here in this case, starting prenatal, but pulling in pediatric and adult. How do we pull this all together for families? So in this case, there was a 32-year-old female. She was pregnant for the first time, coming to her routine anatomy scan at 20 weeks. She was found to have a singleton male fetus. And on that ultrasound, as you can see here by the arrows, bilateral cataracts were detected. As we know, there's hundreds of genes, non-syndromic, syndromic causes of cataracts. If I'm thinking about males with congenital cataracts, I'm really starting to narrow that down to some X-linked causes, but still lots of different options. And we don't have a lot of information as of yet, just because it's the ultrasound. But interestingly, at the same time, her sister was also pregnant with her third child. She had 2 female children prior, and she was now pregnant with her first boy. Within a couple of weeks, she was ready for her 20-week anatomy scan. She was also found to have singleton male fetus, and bilateral cataracts were also detected in this child. So we're starting to gain more information. 2 female sisters, they each have a male fetus, both have cataracts. This is really looking like X-linked, but can we do anything more? Still could be dominant, we don't know. We should be looking at other people in the family, really pulling in that phenotype. So the mothers were assessed. So this are the slit lamp photos of the first mother that was seen. She had sutural cataracts in both eyes. And this appearance here that you're seeing on the slit lamp and really nicely on the retro is the lens appearance that we see in the sutural cataracts of carriers of Nance-Horan syndrome, a known X-linked disorder that causes congenital cataracts, dental anomalies, and intellectual disability in males. We also saw her sister. She also had sutural cataracts of both eyes. So again, firming up our phenotype throughout the family in adults and in the fetus. When we ended up doing genetic testing, we sent for a next generation sequencing panel, and it found a novel pathogenic frame shift variant in Nance-Horan syndrome. And so this was straightforward as far as it being pathogenic because of the variant type and the loss of function, but it was a novel cause in the family. We did cascade testing in all the apparently affected individuals postnatally, as well as in a previously unknown affected sister sibling. And everyone was found to have the variant. So it really tracked with the phenotype that we were seeing. And so to throw the whole pedigree out there for you to see, now that I've described it all, we did appreciate additional features of the syndrome when we were able to clinically examine them, like microcornea. One of the sisters had a few absent teeth as an adult that never formed. So it really pulled everything together, and we did the cascade testing to show clearly how this went through the family, and it informed a lot of different things, but it was really these multiple phenotyping strategies that we utilized and leveraged together with genetic testing to get to that crucial and critical diagnosis early on, within days of delivery. And using this fetal parental phenotype, that was a unique approach, but it really allowed us to do this quickly and potentially can be useful for other undiagnosed families. The second case I'd like to present to you is a 6-year-old female. She had a history of myopia, reduced vision, and an abnormal head posture. She had had care elsewhere, but was presenting to us for the first time. On her dilated fundus exam, we were able to appreciate here in her right eye some hyaloid vascular remnants with macular dragging, straightening of the retinal vessels, and she did have regions of peripheral avascularity. As one representative photo of her peripheral avascularity, I have her fluorescein angiogram here, where you can clearly see that demarcation of the vascular versus avascular zone of the retina. So from taking these clinical pictures and the phenotype is starting to evolve down to familial exudative vitreoretinopathy, that's where we are leading. We are always thinking about the family because a lot of the FEVR conditions are inherited in a dominant pattern. And as you can see here in this pedigree, there was no known family history, but we had a strong clinical diagnosis. We went ahead with genetic testing at that time with a vitreoretinopathy panel, and we found that she was heterozygous for in a large deletion that took out the canonical splice site and 89 more base pairs into the intron. So it was going to result in some abnormal splicing in the LRP5 gene, which can cause dominant or recessive FEVR. Now, she had no additional variants at that time. We went back to the laboratory and asked again just for them to double check it, but all we were left with was this VUS. So what did we need to do to help understand this as the potential cause, since this could be dominant? The next natural thing we did was go to the parents, who they disclosed no known history, but here is dad's fundus photos. So as you can see here, particularly more in the right eye, we have the straightened retinal vessels, some curious things may be happening out there in the periphery at 10 o'clock. So he had features of FEVR, which we know can be very widely variable and asymmetric, even in patients that we see, may not always be apparent in the family history. This is his autofluorescence as well. So what are the implications of this? We helped gather additional clinical information to go back to the laboratory and say, well, now we have another affected individual in this family. Maybe this variant is no longer a variant of uncertain significance. Can we use that phenotype information from family members to help influence the genetic test result? But another point I'd like to bring up is LRP5 is required for Wnt signaling, as a lot of the FEVR-related genes do, and it actually has a role in bone mineral density. And so you can see a decreased bone mass and increasing the risk for fractures in these patients. So monitoring by DEXA scan and also introducing some medication options to help with the bone mass is an option for them. And so one thing I'd like to propose when we talked about genetic testing may not always be available. It's a risk in the FEVR patients that they could have this bone condition, and perhaps in the absence of genetic testing, this might be a strategy for management. Our patient, fortunately, on her initial DEXA scan had normal bone density. So to conclude, ocular phenotyping achieved a clinical diagnosis here in the second case as well that had multiple positive impacts, pulling phenotype and genotype together. We influenced the variant interpretation. It was elevated to likely pathogenic. We directed appropriate extraocular investigations and identified at-risk relatives who didn't know that they had the condition. And as I already said, that maybe with strong phenotype-genotype correlations that exist, even if you're unable to get genetic testing, thinking about, are there other non-genetic types of assessments that we're going to be able to do to help our patients globally and help inform their medical care? Thank you.
Thank you, Dr. Hannah, for the very insightful presentation. You, I think, covered most of the topics that I was always wondering about. I have one very different question, something that I look forward to, is what role do you think artificial intelligence and bioinformatics tools, do they have a role to play when we talk about phenotype, genotype correlation? And if there are some tools already, how can we start using them? Because that will make a lot of difference in our catching of these syndromes.
Yeah, there's a lot of emerging tools that I've seen out there because typically people think about the traditional bioinformatic tools. There's Polyphen, there's SIFT, there's Mutation Taster, right? Ones that have been around for a very long time. But there are a lot of newer tools that are coming available. But of course, they are all considered research-based tools. And I would again stress this is only one line of evidence when we think about variant interpretation. So bioinformatic tools have their role, but they are not a standalone when we think about interpreting a genetic test. Some of the newer tools that I find helpful, there's a website called Varsome, Varsome. And when it comes to the ACMG criteria for variant interpretation, you can actually toggle on and off the different criteria, which I find helpful if I'm thinking about my patient. We're gathering more information. There's more happening in the pedigree now, more results coming in. You can click on the one and say, well, now I know this is in trans, or this is segregating in the family, and kind of bring in bioinformatics meets those other lines of evidence that really are necessary to correctly interpret genetic testing. Franklin is another tool that I've seen come available. So I think with AI and pipelines for genetic interpretation, I think they're going to increase. But we always have to remember that that side of it is only one piece of evidence of a larger picture.
We have a comment from Dr. Elias as well, also.
Yes. So I know we're all excited about artificial intelligence. Let's go back to the basics. The two cases that Hannah presented tell us one extremely important thing, which is look elsewhere. Okay? Look at other clinical findings, the teeth, the hands, the development, the bone, whatever, because about half of the patients we see, if not more, have something else other than in their eye. So start there, and I bet you can, if you cannot make a very precise diagnosis, you can at least put them in a category of diagnosis that is different than just having an eye problem. So do that first, and then maybe you can, even if you did a Google search as simple an artificial intelligence test as or tool as you may have, you might narrow down your differential diagnosis or hone down on a very specific one. Nance Horan syndrome, you should be able to diagnose it without doing a genetic test.
Well, two things to add to that. I'm sorry. One is that we cannot take for granted that healthy individuals are really healthy. So we should examine and get as precise as we can the phenotype of those that we think initially are going to be non-affected, because that has very significant impact in terms of testing and in terms of interpreting the results. And also talking about AI, right now there are some tools that, for instance, using autofluorescence in some of our patients, we can have some very important pointers towards what genes to look at. Just one note on that.
Great comment.
I just wanted to make a point. I would like Divakant's opinion on this as well. See, the way I'm looking at it, we got young ophthalmologists listening to this webinar, hopefully, and AI is sexy, AI is like exciting, but I think the basic things like, what is next generation sequencing? I mean, I have parents where the results come back negative, and they go, but you said it was this condition, how can it be negative? And then I tell them next generation sequencing. This is my analogy, and I'd really like to hear Divakant's, Eduardo's, Ramesh's, and Elias's. My analogy is this: if I lose my keys, and Hannah will smile because she's always in the room when I say this. If I lose my keys and I say to my wife, "Where are my keys?" She says they're in the bedroom. Well, I'm programmed to look in three places: by the bedside, on the counter, and by the chair. And if I don't see them there, I go, they're not here. So she comes up, she looks at the whole room and finds them under the bed. Next generation sequencing is me looking in three places, the places where they're most likely to occur. So I think for young ophthalmologists, they need to understand that. They shouldn't get frustrated. So what is the analogy that Eduardo you use, Divakant you use, Elias, Ramesh, Deepika? I want the young ophthalmologists to have that as an armamentarium to deal with disappointed parents.
Well, I usually say that if you have pneumonia can have many different causes, and you may not even find the cause, but that's it, you still have pneumonia. When it comes to RP, I can ask for a gene test, and I immediately tell parents that if you if you have a negative answer, it simply means that the technology that we're using is not effective enough to find the culprit. So don't expect to have always a positive answer.
One of the best ways to avoid disappointments is not to raise expectations a lot in the first place, and not to say, oh, we're going to do the test, we're going to figure out what the gene is. You're going to tell them, we're going to do a test, and there's a good likelihood that we might find a specific answer. But even if we did, it may not help immediately. And if we don't find it now, we'll find it in 5 years when treatments will be available. And this way, when the result comes back and you couldn't find the specific gene, it's easier to relay that kind of news to the family. Expectations are very, very high, especially in countries and environments where this testing is readily available, and it's no longer only extremely educated people. Everyone knows it. So this has nothing to do with the level of education either.
Dr. Divakant, what's your perspective?
Yeah, Dr. Cannon. So as retina specialists, we are very good at handling disappointed patients. But I think the key to this would be a good amount of chair time. You need to discuss with the patients, and the things that have been discussed today. A lot of times you might not get positive results. And yes, we have faced this after sending a patient for an MRI and it comes back normal. They are very disappointed that it's normal. But of course, genetic testing is a different ball game. But you need to understand, as Dr. Elias said, that it's a developing science, and we are learning on the go a lot of things. So we need to wait for better times and for our knowledges to increase. Yeah.
I think a lot of us brought that up, is that what about waiting, right? We're constantly learning more. When do we go back? How frequently should we go back? How long do you wait, right? Because patients are anxious. We didn't get the answer the first time. Now they want it. What are our practices here on the panel? So we'll start with you, Dr. Divakant, because we were just speaking. How long do you wait till you go back to maybe repeat a genetic test that maybe our knowledge has expanded for, or reanalyze our existing data?
See, again, it's a very individual thing. A lot of patients in India, we do have to pay. They have to pay out of their own pockets, and these are expensive tests. So we need to discuss with the patient. It's not a very general answer that I can give to that question, but it depends a lot on the motivation of the patient and how they are how aggressively they want to pursue this thing. And then a lot of these patients do want to know the benefits on the actual disease that is going to have. So these things are very tricky, and it's very difficult to come up with a general answer. Yeah.
It looks like in India, Divya, that you go straight to exome sequencing. So in the setting of going for an exome sequencing, repeating, I don't know that it's as important as when you do next generation sequencing and certain panels, which we do in the US, and then periodically, is there a bigger and better panel than there was 3 years ago, and then we repeat it. But if you go for the exome sequencing from the get-go, the likelihood of having missed something is very low, and maybe a reinterpretation of findings becomes more important. Maybe the variants that were found initially were interpreted one way, and now they're interpreted in a different way. So you don't need to repeat the test. You need to just re-examine the previous data, and this is where you can call the lab or have your genetic counselor call the lab and say, okay, this was done 3 years ago. Is there a reinterpretation that could explain my patient's phenotype?
I think also it's important to have a very good relationship with the lab, what you're dealing with, and your team members. I think Gauran team does very well. Triage is very important. This is the patient is going to get married. They want some answers very quickly. Sometimes that is very important. I think triaging, the turnaround time and reanalysis, it depends upon, we need to make a list of patients when you have a long list of patients. I think that's very important. And as Ken said, I think you have to set the expectation, not like switch on and off, like getting a OCT image. It's not like that. We might get a high probability of your answer, but we will do all the analysis required for that particular testing. That's what I think one of the things we tell the patients. Thank you.
So when we're thinking about all of these, right, these are tasks for the future, and this is a perfect transition for none other than Dr. Nishal to present to us next about future-proofing ophthalmology. We need to be thinking ahead for our patients, and he's going to give us those insights on where we are headed. Dr. Nishal?
Thank you so much. I hope you can see my presentation.
Yes.
Okay. So future-proofing ophthalmology, where is ocular genetics heading? And this may not be exactly what you thought it was going to be, but I hope you enjoy it. These are my financial disclosures. Even though I am an advisor for a gene therapy company, I'm not discussing their product at all. I have 2 molecule patents pending, again, not relevant to the talk. So, I thought about future-proofing ophthalmology, and the way you future-proof things is through education and training, understanding the therapy techniques that are available, being aware of clinical trials, and really reading up and making sure that you have a good understanding of what's available and what is it that you can do. Why education and training? Well, we need to be able to speak the same language. We need to understand common concepts, and there needs to be a shared learning. So, and we need to then understand how to use the tools that are available to us. I love this cartoon, right? If we don't understand the terms that geneticists are using and ocular geneticists are using, then you might be thinking of pie and somebody's thinking of another pie. And that causes confusion. And this is me in 1998 when I went for my fellowship in Toronto, because I had never even understood that genetics was something I might bring into my clinical genetics. And I really felt like this caveman with a computer, and I didn't know what to do with it. So I think it's really important to understand the barriers to clinical genetic testing. And in centers where clinical genetics is not routinely offered, the major barriers include lack of provider confidence in genetics knowledge and information, and lack of time. I've been to India where they're seeing anything from 200 to 300 patients in a day. How on earth do you do anything that is clinically relevant from a genetic point of view? Well, this is what you do. The most basic thing is to sit down and learn how to talk to parents and patients and take a pedigree, a 3-generation pedigree. And this one is de-identified and given to me by none other than Hannah. And it's drawn. You don't have to have lovely stencils. It's drawn, and you have to have a key. And that is the most basic thing that you can do. So in 2011 and 2012, the question came to us through one of our thesis students here at Pittsburgh is, can we develop genetic educators? And the idea was that we wanted to see if you could train paramedical staff and optometrists to be able to take a reliable 3-generation pedigree. And that was the aim. And the aim was, can you train people sufficiently with enough knowledge to be able to start to do that? And what does it take to get them to start doing 3-generation pedigrees? So we had 10 ophthalmic centers right across India. Ramesh Kekanuya was part of that group. Vinay Gupta also, many of you'll recognize those names. And we had 26 participants. And this is what we did. We did an online course for 7 weeks, pre and post testing. We then went in person and reviewed the course details. So people, if they were confused, we could clarify that. We implemented for 6 months, and then we went and did a non-interventional evaluation. And these were the genetic educator training courses that we developed. And this is what they look like. They were housed on WSPOS, but also at the University of Pittsburgh. And you would play the module, and then there would be pre and post test scores. We'd examine whether the comfort in genetics had improved. And we looked at clinical observations to see, was there disruption to the normal flow? And here are some selected results. Every single module showed a significant increase in knowledge base. Every single one. Then we found that during the 6-month implementation period, there were no adverse events. No families threw their hands up. Nobody tried to kill themselves because somebody had said something inappropriate, because this was all very stringent. These were not genetic counselors. These are people who would be giving education to take a 3-generation pedigree. And about 500 patients were looked at, and all of our participants were evaluated. Hannah went, our other 2 counselors went who were there at the time, and the explanation of genetic concepts was only performed by a few individuals. So out of the 26, Only a few tried to explain what autosomal dominant was, what autosomal recessive was, what X-linked was. The majority just took a 3-family pedigree. And you might say that's just, but it is actually quite important. And this was some of the individuals who took part. And towards the end, they were able to take pretty complex pedigrees. This is just an example of one that Hannah's drawn, but they were able to do complex pedigrees. Was one thing that's very interesting. We don't talk about cultural themes. In Delhi, there's a Hindu population and a Muslim population. And you found that the counselors, when they were talking to Muslim population patients, would really try to drill down as to whether there was consanguinity. But with the Hindu families, they wouldn't raise it at all because they were worried that they would offend them. So it's a very interesting, the cultural aspects of genetics is something that we haven't talked about, but it's important to understand. What's really interesting that is all the centers except 2 sustained implementation and had a mushroom effect in training other optometrists and allied health professionals. So look, this project clearly showed that you can implement a basic pedigree-taking allied health professional in these centers. What was striking is that in Chandigarh, they have several glaucoma clinics, and in one clinic, they found a 27-member pedigree, and the members of family were being seen in different clinics. So they were now able to pull them together. So it may seem like, why is he talking about basic training? Because that's important when you have high volume. You've got to future-proof ophthalmics and ocular genetics in ophthalmics. We've got to have basic training, and the modules I talked about will be available for retesting if you want to take them on the 1st of July. All right, I'm sure many of you are interested in therapy techniques. So this is a really nice article, Gene Therapy and the Future of Eye Care, in one of the throwaways. But I find these throwaways are really, they put everything into very simple language. So what is gene therapy? There's gene addition, there's gene editing, and there's RNA modification. Those are your 3 basic gene therapies. There is one more that I'm going to talk about, but to understand what gene therapies are available, you need to understand the 3 basic techniques: addition, editing, which is CRISPR, and RNA modification that affects the gene product and helps skip damaged exons. This is a really nice article as well. You know, where we're making good progress is in single gene defects, and many of you have heard of RPE65 treatment, and that, of course, is the only FDA-approved treatment. But the really important thing is that the eye is an accessible target organ. There are emerging therapies. We can look now with adaptive optics, we can see survival and improvement of photoreceptors. So we have this really important mechanism of being able to see what we're doing and how we improve it. There are not only viral vectors, there are non-viral vectors. And the purpose of this talk is not to explain to you in detail, but for you to be aware so you can go away and read about them. And there are different ways that we can apply these therapies. I've talked about targeted gene therapy, but optogenetics is really interesting. Basically, in optogenetics, you're bypassing the photoreceptor by using a molecule and a camera that, if you like, gets the retinal ganglion cells to see. So this is a new technique too. This is a really nice article, Top 5 Promising Gene Therapies. And this is by Amir Khamisi. Just look it up on the internet. And it gives you very basically all the different things that are in the pipeline and includes the optogenetic. Again, the purpose of my talk today is not to explain to you in detail, but to show you what the vista of future possibilities holds. If you want to find out about clinical trials that are available, go on to clinicaltrials.gov, but please read the study carefully. Anybody, anywhere in the world can put anything up on this website. So make sure, as the US government says, it does not review or prove the safety and science of all studies listed on this website. So make sure that if you're going to use this to inform your parents or your patients, that you've read about it and read if the study is viable. So where do I get more information? Well, we have the person who wrote the first proper book on genetic eye diseases, Elias Trabulsi. It tells me the third edition is coming out. Ophthalmic Genetics is a great journal. You should read it, or you should at least try to publish in it. It's really, really good. And these are all different other texts that are available. You need a basic text with you to turn to at the end of a clinic if there's something that you've seen. The other thing that's available is on lots of websites, but I'm going to talk about WSPOS. If you go to our website and go to the education part, it says Education Forum. If you hit that, we have pediatric gene therapy. And if you hit that, we have videos, podcasts, a supplement, and e-learning. The supplement is done by David Mackey. It's really interesting. It gives you, and in fact, Eduardo is also in there, gave a chapter on that. It's all online. And then there's an actual e-learning. This was by David Mackey to help test your knowledge. So there's lots of things that you can go to, lots of places that you can find out about. And there are podcasts as well about genetics and systemic diseases. We're not the only website, but it's the one I know best. So future-proofing ophthalmology, integrate and instill ocular genetics into core training curricula on a global platform. Be inquisitive. There are so many myopia treatments right now, right? If you have a child who is a non-responder, make a note of the name somewhere secure. Because as we build up the number of non-responders, maybe we can do a whole genome sequence on them and see where the overlap is to find the loci that might make a child a non-responder. The future of ocular genetics is up to you. Be interested, be inquisitive, and participate. Thank you.
Absolutely
Dr. Nicole.
amazing presentation. I think future is where everything lies. And since we have young ophthalmologists who are going to be listening to this, they are the future. So I have a quick question before Dr. Hannah can take a few questions. Young ophthalmologists actually are very hesitant when they order genetic testing. And I believe future is going to be getting them educated on like webinars like this. So I have a quick question. Can we have a practice pattern book? I know we've spoken about this before, where the WSPOS and such an expert panel can come together and we can have some sort of guide, which I know this webinar is not enough. We can, get that going. That'll be something which will be really, really useful for the future.
I would love for YOSI and other YOs around the world for the people who are interested to work with WSPOS, ISCADR, International Society for Genetic Eye Disease and Retinoblastoma. They do a wonderful meeting. It's really, it's one of those meetings where people like WCPOS, people are not judged. You talk, you discuss, and you learn. And it would be great. I'm sure Elias and Eduardo would agree that this would be a great opportunity to develop a preferred practice pattern for young ophthalmologists globally. And we could make it region specific.
I can comment a little bit about that if you don't mind. There are extremes, okay? In Portugal, Eduardo tells me that unless you're a geneticist or a genetic counselor, you cannot even order a test. In the US, that is not the case, but in certain hospitals, you cannot order a test unless you're approved to order a test. So just to have it open very broadly with no qualifications, I don't object to that, but what Ken brought up, and I'm sure we all agree, that there has to be a minimum amount of knowledge and confidence and empathy and consideration of a number of things before you can, because the thing is you can order it, but what are you going to do with the result? Who's going to help you make sense of that and use it to help the patient? So I do agree that having some sort of a statement or some sort of guidelines of what to do and what not to do would be excellent. And I do see an opportunity, Ken, between the International Society for Genetic Eye Disease and Retinoblastoma and WSPOS and APOS and other organizations, the American Academy of Ophthalmology, and maybe all Indian. So there should be a group that would take an initiative to put that together in these times. There's no doubt about it. And I want to take also this opportunity to invite all the audience today to our next International Society for Genetic Eye Disease and Retinoblastoma meeting in Oslo in September. It is going to be available in virtual format too, so you don't have to travel there to attend it. And Dr. Nishal and Eduardo and Hannah and others who have attended can tell you that if you attend these types of meetings, they will add to your knowledge. There's so much variety in them. They go over 3 days. And nowadays you don't even have to leave your home or your center. You can attend it, and the costs are very reasonable. So I add that to the resources that everybody can get to learn more and become more qualified to understand and possibly order these tests.
Well, I would like to add something. We just came out with a paper that provides some guidelines as to what type of testing we should order in cases of IRDs. And the Portuguese Society of Ophthalmology got together with the Portuguese Society of Genetics, and we had a panel of experts from both ends come up with some guidelines for every clinician to be able to use and to do it adequately in accordance to the cases that we have in front of you. And the other thing is, someone mentioned this, keep an open mind always. I mean, these patients, especially the syndromic ones, will not have all the characteristics at the same time. So if you keep an open mind, and the gene testing sometimes will help you get to the right diagnosis, and don't be afraid to change that diagnosis, because sometimes you have someone with a retinal dystrophy that will develop a kidney condition along the way, a few years after that, and the diagnosis will change. It's obvious that we do have, and for the younger crowd, we should all have a checklist of questions to ask the patients and their relatives, because if you don't ask, you will not get an answer. And the patients simply can't think that something that you have in your hair has anything to do with your eye condition or with your toenails or with a kidney condition. And that's my 2 cents. Thank you very much for your attention.
And, we're being made aware of some even more resources that are out there that people are putting in the YouTube comments. So please take a look there. And one emerging trend I've also seen is the offering of fellowships in ocular genetics and ocular genetic counseling. So there are more training opportunities becoming available worldwide. So for trainees, people who are looking to continue to expand that knowledge, these opportunities continue to become available. So we're just about at the end of our webinar. I'd like to go through the rotor here and everybody give one final thought, pearl, lesson, something from today that we can give to all of our attendees. We'll start with Dr. Trabulsi.
Stay with the basics. Ask the most important question for your patients. Do they have an eye problem only, or do they have a systemic disease with an eye problem? If you do that at the beginning of every encounter, and you ask that list of questions that Eduardo mentioned, you're in much better shape.
Dr. Silva, final thoughts?
I think I already gave that. It's get your own checklist of questions, and preferably have another checklist of what types of genetic testings are available so that you can choose wisely.
Dr. Ramesh?
Yeah, try to look somewhere. Clinical acumen is in your brain and in your eyes. Always use that, and be sensitive to socio-economic and cultural situation.
Dr. Nishal, any final pearls to add today?
I'm going to go last.
Okay. Dr. Gora?
Yes, so it's the phenotype and phenotype all the time. So we learned if we have a right diagnosis, phenotypic diagnosis, genetic testing is not required all the time. But if the genetic testing comes differently and what you have an unexpected result, always go back to the phenotype. So your phenotype is an answer for everything.
Dr. Deepika?
Yeah, hi. So I think I would like to add, and I say to all of my patients that genetic testing is not a routine blood test, like we order a complete blood count or hemoglobin. So it's entirely different than a routine blood test. It takes time, it has different implications. So be with us till we find something, or the journey will be very long. So I usually say them. I think this is from my side. Thank you.
And my co-moderator, Dr. Aditya.
So I think having a playbook, like everybody said, is very important. Watch out for the red flags clinically and correlate it as far as your testing is concerned. And if you don't get the right test or the right result, go back, think again, and then decide what you have to do next. I think that is what I would say to recommend.
And is Dr. Divikant still here, or is he having difficulty with his?
He had some difficulty. He's in.
Okay, don't worry. Yeah. That's fine. That's fine. So I'll go next. I'll let you have the last word, Hannah. So there are two things I want to say. Number one, Aditya, thank you so much for reaching out to WSPOS and making this happen. We really, really are pleased to cooperate with YOSI on this. I would say one thing. I would say that when I started in ocular genetics, being able to reach out and speak to colleagues for advice and help was so important. So build up a network of people that you can discuss cases on. If you want, WSPOS now has close to 7,000 members. We have a Facebook page, and people often will discuss things in a very collegial manner. There are lots of other places that you can go to, but it's an opportunity to do that. And I think that I think there's a real opportunity to develop a preferred practice pattern, and we would love to do that with YOSI. It would be phenomenal. So thank you very much for this opportunity.
And I'll have someone else.
After you, I just have something just triggered in my brain. So if everybody would allow on the panel and everybody who presented, we'll generate a YOSI WSPOS pediatric interest group on WhatsApp, where everybody who comes across these cases can share it. Something which is more inclusive, and we can have some resources shared. I think that can be a trigger point for all this. If that's okay with everybody, I would love to add them on the WhatsApp.
That'd be great.
So I have some announcements to make, but before I get to that, my final thought would be that we are looking towards the future, but we need to keep in mind also that nothing is a timestamp anymore. Everything in genetics is constantly evolving. The phenotypes are evolving, as we saw today. And I've seen that time and time again. I have patients from 10 years ago that we're still revisiting and looking at the results again, thinking about it in a different context, not just from their disease, but where they're at in their stage of life. So those are the things that we need to also keep in mind, that when you're doing the genetic test, you get a result. This is not a snapshot in time, and we need to follow these results, these patients, long-term for the best outcomes. I'm going to share my screen again for some final announcements from WSPOS today on our webinar. And so if we did miss any of your questions, we have been monitoring and looking for them. You can email them if we didn't see them in the YouTube chat, and we're going to get our panelists and moderators, our speakers today, to take a look at your questions and get back to you. We have some upcoming webinars in season 6. So webinar number 5 is coming up in just a few weeks, thinking about cystinosis and how it affects the eye. And it's going to be sponsored by Recordati Rare Diseases. There's some other webinars and opportunities coming up. There's going to be some medical education on amblyopia, and a second webinar that we're going to collaborate with YOSI together later this year. And don't forget about September, WSPOS Subspecialty Day in Copenhagen in advance of the ESCRS meeting. Will be a single-day pediatric subspecialty content covering all areas of pediatric ophthalmology. Please pay attention to the WSPOS website for information about the abstracts and registration.
And I just wanted to say, Elias, don't worry. We picked it so that it's a 40-minute flight from Oslo to Copenhagen. And so people can go to both or one or the other. It's both going to be good. So we had no choice because ESCRS already had picked the day.
Not a problem. We hope to see you
We'll be there.
in Oslo. And everybody else, go to isgedar.com. And those of you who are interested, you can register for the meeting virtually.
And if you're not already a member, if we haven't convinced you yet, please take a look at all the benefits of joining WSPOS beyond just these educational webinars. There's access to journals, online videos as were shared, and the membership is free. So go to wspos.org to sign up. And you can also follow on all social medias and listservs. And here's Dr. David Granite's information to join the listserv and think about all of the things that can be offered through all the collaborations and all the information we can share around the world. So thank you to everyone, our audience, my co-moderator, Dr. Aditya, all of our speakers and discussants. We appreciate all of the time, the opportunity to combine with YOSI and everything that we were able to accomplish today. We hope you enjoyed season 6, webinar number 4 of WSPOS.
And a special thanks to Entod Pharmaceuticals for their support for this webinar. And once again, I would like to thank WSPOS, Dr. Ken, Dr. Ramesh, Dr. David, everybody, YOSI, for having this collaboration. And I think it's going to pay off big time for all of us in the future. Thank you so much.
Thank you. Big thank you
all.
to Akila for herding all of us from our admin team.
Big.
Yes.
And can we have
True,
everybody
true.
do your sign since we're all young today?
Oh, yeah.
Quick photo. Just 1, 2, everybody with the your sign, please. Perfect. Excellent.
Thank you.
Thank
Happy
you.
Holi.
Happy
Thank you.
Holi.